Good morning, and thank you for inviting me to speak today at the APNA conference. It's my first conference, so apologies if I'm a bit nervous or sound a bit shaky. So my role today really is to speak about health navigation and the Priority Response Assessment Service. Western Health Links is a 3-year pilot program funded by the Department of Health and Human Services. We are currently in our final year. We are working in partnership with Western Health to try and support patients living at home with chronic and complex health conditions. We support the transition of patients from their hospital discharge into the community and aim to reduce unnecessary hospital admissions through the delivery of two service types, health navigation and priority response nursing assessment. So we service Melbourne's West, which is one of the fastest growth corridors in Australia and also one of the most linguistically and culturally diverse communities. There are 3 acute public hospitals that fall under the Western Health umbrella, and we service about 800,000 people, so just to give you an idea of the demographic that we service. Like I said, the aim of the program is to improve the health outcomes for patients with chronic and complex health conditions through quality healthcare integration and collaboration with patients, their GPs and other primary health networks. As the earlier presentation, healthcare is such a complex area to work in, and it's not just one area. You're dealing with multiple comorbidities. You're dealing with the psychosocial factors, mental health, emotional, drug and alcohol. So these are the types of patients that we see every day. It is a challenging role, but it is also one of the most rewarding careers and rewarding jobs that I've ever had to do. So our health navigators are primarily the face of our program. We are a mixture of allied health and registered nurses, and we assess the risk for a patient's risk for representing to hospital. We do this there are a series of 9 questions, and these are the predictors for a patient's risk for readmitting to hospital. Patients that are a high risk for presenting, we actually visit them in the home. We sit down with them and take a holistic approach. We utilise the Flinders chronic disease management tool. So asking them all of the questions, the holistic approach, patient-centred, we sit down with them and ask them what are their goals, what is their hook, as my manager would say. What is the hook? What's going to get them out of bed every day? What's going to motivate the patient to take ownership and empowerment? How are they going to take ownership of their health? How do we put it back on them? Because that's what's going to empower them. That's what's going to keep them out of hospital. The Priority Response Nursing Assessment is just a bonus to what we offer. The PRA, patients that are identified as eligible, patients that are eligible for our program have access to a 24-hour contact centre. They can call us anytime they feel unwell, and we can visit them at home between 7 a.m. and 10 p.m. And then we work with the patient's GP, and after hours GP if it's after hours. And we can actually ask for guidance and medical governance on what's the best way to support these patients at home. Do they need to go into hospital? Do they really need to go into emergency and wait 8 hours to be seen? So there are 10 key success factors to quality care integration. These are our KPIs in our model are actually, in our program, we base our KPIs on these 10 key success factors. And it really is, the theory behind this is if there are 8 of these key factors that are met, then a patient's risk for presenting to hospital will decrease significantly. So the first one is the identification system. Patients are automatically referred to our program through an algorithm with the Department of Health. If they are frequent ED users, if they have frequent inpatient admissions, and if they have complex comorbidities, they are automatically identified and referred to our service. The minute they hit the emergency department or the hospital at Western Health, there's an alert system in Western Health, and that triggers them for us to go and see them. Advanced discharge program, we work very closely with our counterparts in Western Health. There are internal care coordinators, or what we call the ACE team, and they work with the immediate need for the patient. So if a patient needs PAC services, wound care, Bolton Clark, catheter care and things like that, they will put those services in place, and then we come in and help navigate and do the ongoing support for that. Post-discharge support program, that's when we come in. There is a bit of an overlap between 2 and 3, but we attempt to see all of our patients within 2 to 3 days of discharge from hospital. Number 4 is the expert hospital-like clinical care in the home. So that is the PRA service, and I'll go into that a bit more detail later on. care coordination and care navigation, this is the bread and butter of our job. Our navigators are highly skilled at using the Flinders Care tool, and it is a holistic approach. It's putting the patient at the centre of the care, setting smart goals with them and helping them identify what matters most to them. And then we pop services in place that helps them stay at home well. Number 6, integration with GPs and primary care. We couldn't do our job without GPs and practice nurses. It is such a barrier for patients who don't know how to navigate the health system. Considering about 80% of our patients are non-English speaking, being able to navigate and find a service is really difficult. So we have the support of GPs and primary care nurses and health services to really link them in and refer to services that they need. Post-discharge pharmacy review. So all of our patients, we send a referral for a community pharmacy review at home. 80% of hospital representations are actually due to medication mismanagement in the home. E-health, all of our internal and external care coordinators and health providers have access to a clinical portal where they can access the care plan, appointments and our clinical notes. Advanced care planning, it's about talking to the patient and finding out what matters most to them. What is their definition of quality care at home, and putting that in writing with the support of the GP so they know what they want. And multi-component, integrated and collaborative strategies, working together. So it's about breaking down those silos, working together with all of the primary health services, making sure that the patient is connected, all the specialists are on the same page so that we're all working together to make sure that this patient is meeting their goals and their plan. So just a little bit about the Priority Response Service. We are supported by a national contact centre which is based in Western Australia. If a patient calls us and is feeling unwell, they will be triaged by phone by what we call the Ambulatory Liaison Nurse or the ALN and the Western Health Links team. We are a 24-hour, 7-day phone support, but it is a face-to-face service, so we go out and see them in the home. Home visits take place between 7 a.m. to 10 p.m. and medical governance is provided by the patient's GP or the Silver Chain After Hours GP. We have a turnaround time of about 4 hours. So this is a screening tool that we use. If it's assessed as an emergency response, we always refer to 000. But if it's assessed as a non-emergency response, and if the triage nurse assesses that the patient is safe to wait 4 hours at home, then we will trigger a PAS or a PRA tool. I won't go through all of this, but once the ALN has assessed the patient as safe to wait for 4 hours, our PRA nurse will actually call the patient again, get a bit more of an in-depth assessment of what their symptoms are, and then we can access BOSNet or the Western Health Notes, so we have a bit of an idea of what's going on with the patient, what happened in their last inpatient admission. We call the GP to let them know that the patient has activated a PRA and what's the best way. How does the GP want us to treat this? We can give medication, and we give medication, oral medication, but the GP needs to give us medical governance and a written authority within 24 hours. And then we assess the patient at home, and then there are 3 potential pathways that we can take. So number 1, we can activate a PRA, do an in-home assessment at home, and then a GP review and hospital avoidance. Number 2, a PRA assessment and liaison with the registrar and patient's GP. So if the PRA call is directly related to the patient's last inpatient admission, we can work with the specialists and with the registrars to try and bring that appointment forward if it's clinically indicated. And the third pathway is assessment with GP, working with the ED care coordinators because this patient is not safe to wait at home, so we organise an emergency department admission. I'll go through a couple of case scenarios where we go through each of the 3 PRA pathways, just so you have a better idea of how it works. So the first one is a GP review. So Mrs. Smith, she contacted Western Health Links for the assessment and review of increased shortness of breath on exertion, increased swelling in both ankles. Her exercise tolerance had decreased to less than 10 metres. Her past history was atrial fibrillation, CCF, and her current weight was 63.5. When our nurse got there, there was no immediate red flags, no complaints of chest pain, all her vital signs were normal and within normal limits. The outcome, she contacted the patient's GP who requested a review in his clinic. And the following verbal medication order was provided in the interim. So we had regular Lasix dose for the next 2 days, additional 40 milligrams at 12 p.m, and additional 40 milligrams at breakfast and lunchtime the following day. And then we followed up the next day, and the patient went to the GP, and we avoided a hospital admission. The Rapid Access Clinic. So Shelley, she was recently discharged from hospital following an admission for early cirrhosis. During her inpatient admission, she had 3.5 litres of fluid drained, and they scheduled an outpatient acidic tap or a review in the gastroenterology appointment for 6 weeks post-discharge. We received a PAS tool for assessment of abdominal bloating, intermittent episodes of nausea, and generalised abdominal pain for over 24 hours, and 1 vomit over the course of the day. The vital signs looked good, but when we got there, bowel sounds were active, the abdomen was distended, and she was visibly jaundiced. So we were unable to get a hold of the GP in this occasion, but we were able to speak to the practice nurse who was very familiar with the patient. We then contacted the gastroenterology registrar, who advised that there was no need for ED, but an urgent gastroenterology appointment was required. So that appointment that was scheduled for 6 weeks post-discharge was brought forward to the next week. It was a planned admission, but we were able to avoid an ED presentation. And then we send the prior assessment to Shelley's GP to follow up. So ED admission, we're not always going to prevent ED admissions. This gentleman, 64-year-old, he had chronic abdominal pain. He was on the maximum dose of pain relief that you can be on in the community. Bolus and oral breakthrough. He was on an intrathecal pump in situ, and he called us because he was in so much pain. He had ongoing vomiting and diarrhoea. He had a headache and was generally feeling unwell and lethargic, and he wasn't eating very much at all either. So we spoke to the gastroenterology team, and they requested that an inpatient team review was requested. We needed to arrange an AV transfer because the patient was in so much pain he couldn't walk. And then we liaised with the ED coordinators at Western Health, and they put him on the expected list. So he was able to be seen. He was triaged accordingly, but he was able to be seen. And the ED department, the ED consultant, and the hospital team all knew he was coming in. I have a short video. I'll let Morris tell you a little bit about his story. He's an 84-year-old gentleman who has been on our program since 2016.
My major health issue is I have renal failure, which I've been treated for 15 years, and that's why I'm on medication. But recently I had 2 admissions to Sunshine. One was I fell and had skin grafts, and the second one was just recently where I had a bowel infection, septicemia and cellulitis of the leg. I was discharged from hospital, and the next day the leg swelled up, and fortunately I was given the nurse's name before I left, and I rang, and she was here within an hour. She assessed the situation, contacted the duty doctor on call, and arranged for me to be readmitted to the hospital. Well, I find that I'm virtually isolated from 5 o'clock Friday till 9 o'clock Monday morning because the doctor's surgery closes over the weekend. And should I need any help then, there is an emergency service where a duty doctor who has never seen me before, knows nothing about me, comes to see me. And it's a long and convoluted process where this new service, they come in, they assess you, they can then determine who you need to see and arrange for you to see them and arrange for the transport to hospital, which is a far better and quicker service than I've ever had before.
I'm just conscious of time, so I'll finish the video up. So just in terms of the prior episodes that we've attended, this data is quite outdated. It's in our year 2 of the study. We had 1,099 PRAs in year 2. 70% of these patients remained at home since enrolling onto the program. A bit of hospital data. So we were predicted to actually have a plateau in terms of the referrals that we received. As you can see in Year 3, it's completely spiked. We have a total of 6,802 referrals, and currently 4,000 patients are active on our list. And in terms of price, so hospital days per patient, we have managed to reduce average bed days from 6.03 to 4.55. It's a reduction of 9,556 over 24 months, or 13.8 bed days per day, or a reduction of 24.5%. So as you can see, we cannot always prevent unplanned or unnecessary ED admissions, but it is through liaising with patients' GP, their care coordinators, and really working it for that holistic approach that this need can truly be explored. Thank you.